Good afternoon, everyone. I just wanted to welcome you all to the Coordinated Care Initiative Advanced 1 webinar. This is Justice and Aging, Andretta presenting the webinar, and this Advanced 1 webinar goes into a little more detail on the benefit package and consumer protections of the Coordinated Care Initiative. Now, I'm going to leap ahead a little bit. I'm Silvia Yee. I'm an attorney with Disability Rights Education and Defense Fund. We've been around for about 36 years now, founded by people with disabilities and parents of children with disabilities. We work on national law and policy issues and also in California because we're based here and we're dedicated to protecting and advancing the civil and human rights of people with disabilities. Now I'm going to turn this over to my co-presenter and colleague, Amber Cutler, who will introduce herself and go through the first few slides.
Thanks, Sylvia. As Sylvia just said, my name is Amber Cutler. I'm a staff attorney with Justice and Aging. We are a national nonprofit, and we focus on on advocacy on behalf of low-income seniors, particularly in the areas of Medicaid here in California, Medi-Cal, and Medicare. And with that, I'm going to jump right into our discussion for today. As Sylvia mentioned, this is an advanced presentation on the Coordinated Care Initiative. So we are going to do a quick review of the Coordinated Care Initiative, what it is, who it impacts. We're going to talk about what it looks like to integrate long-term services and supports. We're going to look closely at what the benefit packages are under the Coordinated Care Initiative, and we're going to end the presentation with a summary of the consumer protections that people are offered under the Coordinated Care Initiative. So I always like to start with a glossary. The Coordinated Care Initiative has a bunch of definitions and terms that may or may not be familiar to you. The first being a dual eligible or a dual Medi-Medi. These are individuals who have both Medicare and Medi-Cal health insurance coverage. And this is just one population, one of two populations impacted by the Coordinated Care Initiative. The second population impacted by the Coordinated Care Initiative is that very last term on the glossary page, that's seniors and persons with disabilities, or SPDs. These are individuals who have Medi-Cal coverage only, and the basis for that Medi-Cal eligibility is either age or disability. So when we're talking about the Coordinated Care Initiative, we are talking about it impacting those dual eligibles and SPDs. Another important term under the Coordinated Care Initiative is long-term services and supports, or LTSS. The LTSS definition under the Coordinated Care Initiative is very specific. It refers to four Medi-Cal, primarily Medi-Cal funded programs: the In-Home Supportive Services Program, or IHSS, the Community-Based Adult Services Program, formerly known as Adult Day Health Care, or CBAS, the Multi-Purpose Senior Services Program, MSSP, which is a very small program available to individuals 65 and over who need intense case management, and then finally the Nursing Facility Benefit. So when Sylvia and I are referring to LTSS under the Coordinated Care Initiative, we're specifically referring to those four Medi-Cal funded programs. I'm not going to worry about that definition. Well, a dual special needs plan, or a DSNP, gets thrown around quite a bit. That's a special type of Medicare Advantage plan. Medicare Advantage plans are those private HMO, PPO type plans that if you're a Medicare beneficiary, you can enroll in. Well, a DSNP is a special type of those Medicare Advantage plans that's aimed specifically at dual eligibles. And the way, if you're enrolled in a DSNP under the CCI, your enrollment is treated differently than if you were in some other enrollment category or health insurance coverage option. So you often hear under the CCI the word DSNP being thrown around, and that's because individuals who are enrolled in those DSNPs have a very different enrollment process than those who are not. All right. So the Coordinated Care Initiative, in sum, it is three major changes. The first is that anyone who has Medi-Cal and the 7 CCI counties has to be enrolled in some type of health plan for their Medi-Cal benefits. This transition started back in 2011. SPDs, those with Medi-Cal only, had to join a Medi-Cal plan to continue receiving their Medi-Cal benefits. That has expanded to now rural counties in California, and individuals with CBAS, for example, had to join a Medi-Cal plan back in 2012. So this has been an ongoing transition that's been happening in the state of California. And this change under the CCI is basically that anyone with Medi-Cal really has to be in a Medi-Cal plan or some other type of health plan that's covering their Medi-Cal benefits. So before, there were people who were carved out. So if you were living in a nursing facility, for example, you didn't have to join a health plan. If you had a share of cost, you didn't have to join a health plan. If you were dually eligible, you didn't have to join a health plan. Now you are going to have to join a health plan in order to continue to receive your Medi-Cal benefit. Very few exceptions to that. The second major change under the CCI is the integration of long-term services and supports. In other words, those health plans are now going to be responsible for long-term services and supports. Previously, they were carved out. And to give you a really concrete example, I like to focus on the nursing facility benefit. So before, if you had just Medi-Cal coverage, you had to join a health plan back in 2011. And let's say you needed to go to the hospital. So you go to the hospital, and when you're being discharged from the hospital, you need to go to a nursing facility. Pre-CCI, you could go to any nursing facility, and once you were admitted to the nursing facility, you were disenrolled from your health plan and put back in fee-for-service Medi-Cal. That's no longer the case under the CCI. Now you're in a plan, you go to the hospital and you need to go to a nursing facility, you're going to need to choose a nursing facility that is in your health plan's network of providers. So that's a very significant change to the delivery of the nursing facility benefit. So that's the second major change under the Coordinated Care Initiative. Those long-term services and supports, IHSS, CBAS, MSSP, and nursing facility benefits are now all of the health plan's responsibility. So that's change number 2. Change number 3 is the one we hear the most about, and that's the creation of this new type of health plan that combines someone's Medicare and Medi-Cal benefits under one health plan. And these new health plans are called Cal MediConnect plans. This is a voluntary program, meaning that if you don't want to be in a Cal MediConnect plan, you do not have to be in a Cal MediConnect plan. You can do with what you want with your Medicare benefit. But under the CCI, you still have to be enrolled in a health plan for your Medi-Cal benefit. The way that individuals are enrolled in Cal MediConnect, at least initially and still ongoing in Orange and Santa Clara counties, is through a passive enrollment process. In other words, if you don't make an affirmative choice not to enroll in Cal MediConnect, you'll automatically be enrolled into the program. So those are the 3 changes under the CCI. Again, to reiterate who is impacted, it's those individuals who have both Medi-Cal and Medicare, our duals or Medi-Medis, and those individuals with Medi-Cal only, the SPDs. Individuals who only have Medicare coverage are not impacted by the Coordinated Care Initiative. And to give you a better sense of just how complex the CCI is in terms of who it impacts, I've kind of broken out how people are impacted. So there is a certain category of dual eligibles who are excluded from enrollment into Cal MediConnect. So if you have end-stage renal disease, you cannot, and you're not already enrolled in the program, you can't enroll in Cal MediConnect unless you live in either Orange or San Mateo counties. Keep in mind that there's always an exception to the rule under the CCI, and sometimes there's an exception to the exception. So end-stage renal disease, you're generally excluded from participation unless you reside in a coast county or if you're already enrolled in the program. There are certain zip codes. If you live within those zip codes, you're excluded from Cal MediConnect enrollment. If you're a resident of a veteran's home, you are excluded not just from Cal MediConnect, but you also do not have to join a Medi-Cal plan. Remember earlier I said that there are a few exceptions to mandatory enrollment in a Medi-Cal plan, and being a resident of a VA home is one of those exclusions, as is being a resident of an intermediate care facility for the developmentally disabled, and if you have other health insurance coverage. So if you have Medicare, Medi-Cal, and you also have, say, maybe employer-based coverage, you do not need to join a Medi-Cal plan, and you're not allowed to enroll in a Cal MediConnect plan. And then there are those individuals who are excluded from Cal MediConnect if they don't meet their share of cost regularly, and those who are in a DDS waiver or receiving services at a regional center or developmental center. Again, those individuals still have to choose a Medi-Cal plan, but they cannot enroll in the Cal MediConnect program. On the other side are duals who can participate in Cal MediConnect, but who will still be subject, or who are not subject to passive enrollment. So these are individuals who are already enrolled in PACE, which is a health plan much like Cal MediConnect, except site-based with eligibility requirements. If you're enrolled in the AIDS Healthcare Foundation, if you live in certain zip codes, if you're enrolled, see, for example, in Kaiser, or you're in one of these DSNPs that's not operated by a Cal MediConnect plan, or if you're enrolled in a waiver. You shouldn't get notices about Cal MediConnect, but all of those populations will still have to enroll in a Medi-Cal plan. Again, very few exceptions to that Medi-Cal plan enrollment. I went through that very quickly. I know that is an incredibly complicated set of exceptions and exclusions to enrollment. And for that reason, in the Advocate's Guide to the CCI that Dredif and Justice and Aging have published, and also on the CalDuals website, there are population charts that explain who is subject to what type of enrollment, or if they're excluded from participation in the program. In the event that you think that someone has received a notice in error, the state has put together an email address where you can submit those concerns. And how you do that is you use the email address to flag the issue without any client or patient identifying information. The state will then send you back a secure email to provide that confidential information, or PIH, and you send that back so you can get that enrollment issue fixed. Because a lot of individuals through this process, because it is such an complicated enrollment process with a lot of different populations impacted in a lot of different ways, the state has put together this email address to allow people to submit those concerns to the state to help people get out of the enrollment process when they're not supposed to be in it at all. So there are instructions here on this slide about how to do that and what that email address is. Again, just to emphasize who and how this program works, by and large, everybody has to join at least a health plan for their Medi-Cal benefits, and Cal MediConnect is voluntary. So even if you decide you don't want to participate in Cal MediConnect, or even if you're excluded from participation in Cal MediConnect, most likely you are still fall within one of those populations that have to be enrolled in a health plan for your Medi-Cal benefit. That Medi-Cal enrollment is now mandatory. And to give a sense of, I think I'm handing it over to Silvia now. I apologize. I'm handing it over. So it's going to be you.
Thank you, Amber.
I'm just going to keep on going.
Let me just take back the little. Okay. I'll fix that in a bit. So the next few slides are looking specifically at the changes of CCI to Medi-Cal managed care. And the first thing we're looking at is, so Medi-Cal managed care plans who have been administering Medi-Cal in the past have typically they've taken over the medical portion of your care. You go to that managed care plan's doctors, their medical providers, their pharmacy, etc. The change that the CCI has brought is that in the 7 CCI counties, the Medi-Cal plans are also taking over long-term services and supports, and those are those supports that that Amber has mentioned, the the MSSP. I think the next slide will go into some additional detail about that. But we'll go back to this. The 4 elements of long-term services and supports, as well as nursing homes. So your managed care plan, your Medi-Cal managed care plan, is now administering the IHSS, MSSP, CBAS, and the nursing facilities. However, what that actually looks like is a little bit different. So, for example, the managed care actually has been administering CBAS since, as Amber mentioned, 2012. So if you are a dual or a Medi-Cal individual, a Medi-Cal beneficiary, and you receive CBAS, you have been getting it through a managed care plan all this time. So since 2012. That's been the only way you can get it, except potentially if you have like a medical exemption request. But that's a relatively rare thing now. So CBAS has been put in, and that means that the managed care plans are contracting with CBAS providers. Payment is not coming to those CBAS providers through the Department of Healthcare Services now. It's coming through the healthcare plans. Ideally, for the individual, they continue to go to the same CBAS provider, and those services continue. And again, that was always the ideal. In terms of IHSS, it's what the Department of Healthcare Services has termed a lift and shift. The intention was that the basic structure of in-home supportive services remains the same, at least for a certain period, until I believe it's 2017, so that the county IHS authority is still in place. And for the individual beneficiary, you still have the right to hire, to train, to supervise, and fire your IHSS provider. It's just that the administration above the level of the IHSS county agency is now through the managed care plan rather than, and there's an additional intermediary there between the Department of Healthcare Services and the IHSS Public Authority. So again, at the level of the beneficiary, it shouldn't feel different. MSSP services was also a matter that the managed care plans ideally were contracting with your MSSP providers, Meals on Wheels, different kinds of case management and coordination and service providers. And the managed care plan, through those contracts, would be paying those providers, and the community-based providers would continue to provide services to the Medi-Cal beneficiaries who used those services. That was the hope and the idea behind this transfer, that those Medi-Cal services, those 4 key LTSS services, would remain. As Amber has said, the nursing facility one is a matter that each Medi-Cal managed care plan has to build its network to contract with individual nursing homes. So there was a beneficiary protection in place so that for a Medi-Cal beneficiary who is already in a nursing home, they should not have to change their nursing home if they went into a Medi-Cal managed care plan. For those new individuals who are entering nursing homes, new Medi-Cal beneficiaries entering nursing homes, now they have to find a nursing home that contracts with their specific managed care plan. So looking at a couple of additional Medi-Cal benefit changes, there is a new mental health benefit that came into place in January 2014. And the new mental health benefit is available to all Medi-Cal recipients, not necessarily, yes, to all Medi-Cal recipients, and it is delivered through the Medicare plans. It's a mental health benefit that is meant to address not probably the most serious mental health conditions. It does address a variety of mental health benefits, so some group therapies, some initial diagnoses, and other therapies and services. You can get those now through your Medi-Cal plans. There's also a dental benefit that came into place at the beginning of May in 2014. And the dental benefit restored to all Medi-Cal recipients some basic preventive dental services. Those, however, are not delivered through the Medi-Cal plan. They're delivered through Denti-Cal. So while some plans have actually undertaken some degree of coordination with Denti-Cal, especially in cases that may require that, it's not something that you get typically through your plan. And this is a slide I was looking for before, which talks about the four components of LTSS that are going into managed care. So I'm not going to repeat what I said there, but then you see it again in the graphic where you have CBAS, IHSS, MSSP, and nursing facilities going into managed care, and how each of those can look a little different. The intention always was to try to preserve the experience of the Medi-Cal beneficiaries, so that the providers you had, the services you had before you got Medi-Cal through managed care will continue after. Now looking at the Medi-Cal Connect benefits, moving on a little bit to that, there are a number of benefits that the Cal MediConnect plans offer. And what are those? Well, Medicare, of course, A, B, and D. Part A deals with hospital services. Part B deals with doctors, providers, and Part D deals with the drug benefit. So that's what you get from Medicare. Your Medi-Cal services under Cal MediConnect include everything we've talked about before, all the LTSS services, IHSS, CBAS, the nursing home facilities, and MSSP. There are some additional ones that are specific to Cal MediConnect. One of those is vision, one routine eye exam annually, and $100 towards eyeglasses or contacts every 2 years. That's a specific new benefit that comes with Cal MediConnect, with joining a Cal MediConnect plan. There's also transportation to medical services, 30 one-way trips per year. It's often by taxi or another service that will take you to your medical appointments and back home. And also this additional benefit of care coordination, and that's a pretty critical and interesting benefit to have, and that is a benefit that is valued by a number of beneficiaries, especially those who have complex care needs and who have in the past had to coordinate that care themselves. It means that the plan bears some responsibility for coordinating the different kinds of healthcare services and LTS services that you need, that they will facilitate communication among your different providers. Looking a little more closely at that care coordination benefit, the Cal MediConnect care coordination benefit is supposed to be person-centered. It is really supposed to pay attention to the beneficiary and the needs of the beneficiary, social needs as well, and not just medical needs. It is supposed to focus on the least restrictive setting for the beneficiary. So if that beneficiary desires to be in the community, that's something that the care coordination that the care coordinators on the plan really need to pay attention to, are required to. There is a health risk assessment component, so that as a new member entering the Cal MediConnect plan, you are supposed to receive an overall assessment that, again, looks at your social goals, your own goals for your life, or your client's goals for their life, and not just their diagnosis or medical health needs. There's a requirement for an individualized care plan, especially, and for those individuals with complex care needs, especially. And the plan provides an interdisciplinary care team if that is the desire of the beneficiary, and that can include your providers, yourself, the individual with a disability, the beneficiary, as well as the individual's, let's say, their family member, if they wish, or their care providers, their IHSS care providers, and or friends, it's meant to be the ICT, the interdisciplinary care team, is meant to be a multidisciplinary approach to helping the individual stay healthy and functional and well in the fullest sense. The Cal MediConnect benefits also include care plan options services, and the CPO services are a new thing. They were meant to be home and community-based like supports and services. They are discretionary. They're up to the plan whether they will provide them or not. They're not a requirement. They're not a Medicare requirement or a Medi-Cal requirement. And they can't be given as in some kind of a trade with other required benefits. They are supposed to be in addition. So when a new member enters the Cal MediConnect plan and undergoes a health risk assessment, if it seems that there are some unmet needs there, then the plan can decide to provide CPO services. And these could be anything from like someone who has a newly acquired mobility disability or a long-term one requires some home modifications, a ramp or some additions to their bathroom to help them continue safely in their home. It could be something like assistance, an assistant who will help them read mail if they're blind or visually impaired, since historically that hasn't been an IHSS service. So these are additional needs that are unearthed during the health risk assessment and that the plan can choose to meet to help the individual stay safely in the community. There are also some Cal MediConnect benefits that are carved out from the plan. So these are primarily around specialty mental health benefits and some substance use benefits. And there are benefits that accrue to Cal MediConnect members, but they're not administered through the plan. They're administered through the counties because the counties had an existing network of providers and expertise. So examples include intensive day treatment or inpatient psychiatric services that are not covered by Medicare. These are Medi-Cal health benefits. Day rehabilitation, crisis intervention, adult residential treatment services, and particular things like methadone therapy for individuals who have used heroin in the past. All these kinds of specialty mental health benefits that are carved out from the plan's administration and delivered through the county. As mentioned before, also the dental benefit is it's a carved out benefit that is not administered through the plans. So I think this now turns back to Amber. I'm just going to briefly ask if anyone has any questions and invite you to put any questions that you have, to type them into the chat window, and we will be happy to address them as we go along.
Any questions, Silvia?
There are no questions in the chat window, so okay. I will let you know if it comes up.
All right. We've added this slide to the advanced presentation because one of the things that's happened with enrollment under the Coordinated Care Initiative is a large number of dual eligibles decided not to participate in Cal MediConnect. So they opted either to remain a Medicare fee-for-service or they remain enrolled in some other Medicare product, and then they're enrolled in a Medi-Cal managed care plan. So there's a very large number of dual eligibles who are either in fee-for-service Medicare or some other Medicare product, and then they're enrolled on a Medi-Cal plan on the Medi-Cal side. So in that instance, what is the Medi-Cal plan responsible for? And as a dual eligible, someone who's just enrolled in a plan on the Medi-Cal side, the Medi-Cal plan is going to be responsible for benefits Medicare does not pay for. Most notably, that's going to be those long-term services and supports. Those are Medi-Cal, almost primarily funded Medi-Cal benefits. So in-home supportive services is a Medi-Cal benefit. MSSP is a Medi-Cal benefit. The community-based adult services is Medi-Cal. And by and large, nursing facility is a Medi-Cal covered benefit. Medicare pays for the first portion of a nursing facility admission in certain circumstances, but only up to 100 days and only a certain percentage. So those long-term services and supports is what the Medi-Cal plan is going to be responsible for. The Medi-Cal plan is also responsible for some transportation benefits that Medicare doesn't pay for. That's going to be that non-emergency medical transportation that people need who, for example, need to travel by litter van or a medical mode of transportation to get to their medical services. Medi-Cal also pays for some durable medical equipment costs that Medicare doesn't pay for, some prescription drugs, and some supplies, for example, incontinence supplies and things like that. So those are all things that the Medi-Cal plan would be responsible for if you're a dual eligible, because generally speaking, Medicare is primary and then Medi-Cal is secondary, but there are some things that Medicare doesn't pay for that then the Medi-Cal plan would be responsible for. So it would be really important if you were using those services that you would have to use providers that are contracted with your Medi-Cal plan. The other big thing that Medi-Cal plan covers is the cost sharing. So generally speaking, Medicare pays 80%, and then the Medi-Cal plan would be responsible for the cost sharing, the 20%, if in fact it was payable. So you go and see your primary care physician, who's your Medicare provider. They're going to submit that claim to Medicare. Medicare will pay 80%, and then that claim would go to the Medi-Cal plan to pay the 20%. In this instance, the Medi-Cal plan is just taking the place of the state for payment. A big problem with what's going on today is that the Medicare providers will tell their patients that they will not see them because of the patient's enrollment in a Medi-Cal plan. Basically saying we're not contracted with that Medi-Cal plan, so we're not going to see you. Or the other scenario is we're going to charge you for that 20%. Neither of those things should happen because the Medicare provider does not need to be contracted with the Medi-Cal plan in order to bill the Medi-Cal plan for the cost sharing. Instead, the Medicare provider can submit that claim to the Medi-Cal plan just like they would have submitted, well, the process is different, but just as they would have submitted it to the state for payment. Keep in mind that most of the time, primary care physicians and specialists aren't going to see that 20%, and that's because the Medicare rate is it's so much higher than the Medi-Cal rate, and Medi-Cal only has to pay up to the Medi-Cal rate. So those providers don't actually get paid that 20%, regardless of whether it was the state or the health plan paying. But a lot of times those providers still want that opportunity to bill. And so it's really important that people understand that they do not have to be contracted with the Medi-Cal plan to submit the claim to the Medi-Cal plan. And under no circumstance should they be billing the dual eligible for the cost sharing. Almost across the board, balance billing is prohibited of dual eligible beneficiaries. There are both federal and state protections against balance billing of dual eligibles. So I just want to make that clear. That's become a very big issue under the CCI and just generally across the state of California and nationally. But it's kind of magnified because of how many dual eligibles have now enrolled in Medi-Cal plans and then are continuing to see their providers in fee-for-service or in a Medicare Advantage plan on the Medicare side. So with that, I'll move on to the next slide, which is talking about the consumer protections under the CCI, and specifically for Cal MediConnect, the continuity of care protections. So continuity of care is the ability for an enrollee to continue to see their out-of-network providers for a certain period of time. So they've joined a health plan, and their providers are not contracted with that health plan. So continuity of care protections allow the member to continue to see those providers, even though they're out of network, at least for a period of time. Keep in mind that these protections are the minimum protections. The health plans can provide expanded continuity of care protections if they so desire. So the continuity of care, if it's a Medicare provider, would be for 6 months. And by and large, we're talking about Medicare providers. But for whatever reason, if it might be Medi-Cal, it would be 12 months. And there is a link there to the continuity of care dual plan letter. There's criteria, though, that you have to meet in order to be afforded continuity of care protections. Most notably, you have to have a pre-existing relationship with that provider. And to demonstrate that pre-existing relationship, if it's a primary care physician, you had to have seen that primary care physician at least once within the 12 months preceding enrollment into the plan for a non-emergency visit. If it's a specialist, it's twice. The plan is supposed to use the utilization data that it gets from CMS and the state to kind of determine if that pre-existing relationship exists. And it's only if they can't establish that pre-existing relationship through the utilization data that they'd ask the member or the provider to provide proof of that pre-existing relationship. In addition to that pre-existing relationship, the provider must agree to accept payment and enter into an agreement with the plan. The plans have to offer the same rates that the provider would have received under fee-for-service rates. So the payment is not usually the issue, and usually that's like a one-page agreement that they enter into with the health plans. Although we do continue to see pushback in that, for whatever reasons, the fee-for-service providers don't want to enter into even those single-case agreements for continuity of care purposes. And then finally, the provider can't have any documented instances of quality of care concerns that would have prevented the health plan from contracting with them as a contracted provider under their guidelines to begin with. So those are the three criteria to establish continuity of care. You have to have a pre-existing relationship, the provider must agree to accept the payment, and the provider can't have any quality of care concerns. So if all three of those criteria are met, the plan will offer the member the ability to continue to see those out-of-network providers for at least up to 6 months. Again, with the ability to extend that if the health plan thinks that basically doesn't want to disrupt that relationship yet. There are some exceptions to continuity of care, the big one being nursing facilities. So if you are someone who is residing in a nursing facility and then enroll in a plan, so you've already been in the facility, then you can continue to reside in that out-of-network facility indefinitely, as long as you need nursing facility level of care. So it's sort of a carve-out, recognizing that forcing people to move out of their out-of-network nursing facility after 6 months would be beyond disruptive, since that's their home. Durable medical equipment providers, on the other hand, and ancillary services, continuity protections don't actually apply to those providers of those services. So if you were getting your wheelchair service at a certain provider and that provider is not contracted with your health plan, you're going to have to change that provider, and there's no 6 months continuity of care protection afforded. The regulation states or the rules states that continuity of care does not need to be afforded to those providers. Keep in mind, however, that the services are still have to be provided. So even though you can't go to see the same provider that was servicing your wheelchair, you would still have, the health plan would have to supply an alternative provider to service the wheelchair. So its continuity of care is provided with regard to services, just not to that particular provider. And the same goes for ancillary services like pharmacy or labs. So the continuity of care protections don't apply there. They also don't apply to carved-out services, and that makes sense because the health plans have no control over the carved-out services, so they can't guarantee continuation of services or a provider with like with the county mental health or with a particular dentist under Denti-Cal. So those protections aren't afforded there. And then IHSS, continuity of care is not really required because under the IHSS program, a beneficiary remains in control of who they want to hire and fire or supervise as their IHSS provider. So that control is completely within the control of the actual member. So continuity of care it's inapplicable, basically. Some additional things about continuity of care: prescription drugs. Part D rules apply, which is really easy and consistent. So Part D rules allow someone one-time refill up to a 30-day supply, a lesser amount if a lesser amount was prescribed, of any ongoing medication within the first 90 days of plan enrollment. So in theory, this is a really great protection because in theory, you go to the pharmacy and your drug's not on your new health plan's formulary, there's always going to be at least a one-time refill. However, the problem in practice has been that pharmacies don't recognize or don't understand that protection, and so end up telling those individuals who show up at the pharmacy that their drug's not covered. It's usually a simple fix by just calling up the health plan, and the health plan gets it resolved, but it's unfortunately in practice a problem with pharmacies not having enough education on that issue to prevent the disruption. There are some additional protections for residents in nursing facilities, and under Cal MediConnect, the Part D rules apply to both the Medicare-covered drugs, so what your Part D plan would have been responsible for, and also those Medi-Cal-covered drugs, of which there are some of them that Medi-Cal covers that Medicare doesn't cover. So pretty good protection there with some problems in practice. Some other protections under continuity of care. The plans have to complete services for acute, serious, chronic pregnancy, terminal illnesses, and surgeries that are scheduled. There were some updates to the continuity of care protections that made them better in practice. For example, not just the beneficiary can request continuity of care, so can their provider. There were some time limits shortened that health plans must grant those requests. So they have to be processed within 3 days if there's a risk of harm to the beneficiary. And a lot of health plans are processing those requests within 24 hours. So that's been really great. Another good protection is retroactive continuity of care. A lot of beneficiaries were passively enrolled into these health plans and didn't know they were passively enrolled, didn't know that their health coverage had changed. And so then they go to their doctor, and their doctor may or may not check eligibility at that time, especially if it's a doctor that they've been going to for, pretty consistent basis for a long time and pretty regularly. They might not check eligibility right away at every visit. And so what this allows is that, so you go to the doctor, they don't check eligibility, or maybe the eligibility system's not up to date. You see that doctor, and then the doctor then submits their claim either to Medicare or maybe to, Cal MediConnect, and it turns out that they're not a contracted provider. As long as they've submitted that bill for payment within 30 days, the Cal MediConnect plan will pay retroactively so that individuals who are enrolled passively aren't stuck with a bill from their provider, which they can't pay anyway, because of passive enrollment. So that was a really great update to the continuity of care protections. And then finally, the ultimate, continuity of care protection for individuals on the Cal MediConnect program is always the ability to disenroll from the program. They disenroll and they can go back to fee-for-service Medicare, or they can decide to enroll in some other Medicare product. But they always have that option. They can do what they want to do with their Medicare benefit. They do have to remain enrolled on the Medi-Cal side, but on the Medicare side, they can go back to fee-for-service Medicare or some other Medicare plan. And then they just stay enrolled in the Medi-Cal plan. And that disenrollment can happen at any time for any reason. There's no, they don't have to have a reason to disenroll. And then it becomes effective the first day of the next month. So if they disenrolled today, that disenrollment would become effective as of October 1st. And then finally, on the Medi-Cal side for continuity of care protections, it's pretty much the same as Cal MediConnect, except if it's just a Medi-Cal covered benefit or a Medi-Cal beneficiary, you get 12 months. And again, nursing facility residents can continue to reside in an out-of-network facility. Keep in mind, though, if they weren't residing in that facility, they would have to choose an in-network provider nursing facility if they were enrolling. And then the medical exemption request is available to those with individuals with Medi-Cal only who are residing in the two-plan counties, so like Los Angeles or the geographic managed care counties, and so like San Diego, the medical exemption request is available. That's the ability to stay out of a Medi-Cal managed care plan if you have some sort of complex medical condition and your providers are out of network. But keep in mind that the MER process is not available to duals. Since Medicare is the primary payer there, and so they can continue to see their Medicare providers. So the MER is pretty much available just to the Medi-Cal only beneficiaries. All right, I'm going to stop there and then hand it over to Silvia to finish off with consumer protections.
Well, yes, but I'm also going to give you a couple of questions, I think. How's that?
Okay.
We do have some that have come in.
Great.
One of the earlier ones was, let me just find that, the same one. There was a question about, can you expand on IHSS and MSSP and the level of participation by the managed care plans? Will the IHSS and MSSP staff remain in place? Please explain what the managed care plans will be reviewing for and implementing with both programs, which is a great question.
It is a great question. I'll start with IHSS. So right now, IHSS looks exactly the same to the beneficiary as it did prior to the CCI. The beneficiary retains the right to hire, fire, and supervise their IHSS provider. The county is still responsible for determining the level of need and hours, and the county social worker is the one who would participate on care plan meetings and such. Right now, the health plans are sort of the fiscal intermediary, is the best way to put it. That could change moving forward, and we don't know what that would look like yet, but right now, that's the way it looks. And the way that the health plans really play a role right now is actually, hopefully, is increasing access to IHSS. So all the health plans have to do a health risk assessment, and the goal of that is to kind of see what unmet needs individuals have, and it could be IHSS, and then referring them to the county for an IHSS assessment, hopefully helping with filling out the physician certification to get IHSS services. If it's a Cal MediConnect enrollee who's already on IHSS, it could be like through the care planning process, seeing that maybe they need increased hours and trying to work with the county to get those increased hours. So hopefully what we'll see right now with IHSS is an increased referral to the program or advocacy with the program to get increased hours. MSSP is different. The Multipurpose Senior Services Program, for right now, the health plans have to contract with all of the MSSP sites. So right now, they have to, yes, use this, the same MSSP staff that are currently in place and that people have access to. That is only up and through. It just changed under the budget discussions. I think that MSSP was able to get it through the demonstration period so that the health plans have to contract through the entire. I'm going to forget this exactly. I think there are two criteria, either a length of time or until the health plans can prove something has happened. But in any case, right now it does remain the same. They do have to contract with them. I think that there is discussion about taking MSSP, quote unquote, in-house. But I think by and large, I would argue that as an advocate, recognizing the the quality of the services that MSSP sites provide, the extent of the intense case management that people receive that are enrolled in that program, that it's ideal to keep the MSSP sites that have been providing those services continue doing them. No matter what, the health plans have to continue to provide MSSP. It's just that after a certain period of time, they no longer have to contract with the MSSP sites. Though I'm hoping that the health plans recognize that those local relationships and those individuals who have those community connections that are doing those services right now are best suited to continue to provide those services. And I think we've seen even that happen with health risk assessments. Some of the health plans have contracted out with third-party contractors, where other health plans have contracted with sort of community-based groups. And I think we're seeing that those who have contracted with some that have the local connections and relationships with the beneficiaries are better able to complete those sort of health risk assessments. That sort of flows through to who's best suited to continue to provide the really intense case management. Those who have been doing it for years and years and who have those community relationships seem to be the best suited. But again, legislatively, the MSSP program could change pretty significantly moving forward.
Right. I'm just adding one thought on that was that when it's hard for us to know exactly what plans are looking for and how they will assess the programs. I think one thing that is pretty important to plans is sort of seeing a value added. So to the degree that community-based organizations really demonstrate their expertise and their value, they have those relationships, they know the resources that are in the community in depth, that they forge a relationship with plans, with nurse case managers, et cetera. I think that all of those things help the community-based organizations to really demonstrate their value to plans, and as a practical strategy is a good thing, because I believe those community-based providers are invaluable. There was one other sort of question. I've answered a couple of them in the chat box, but I was just wondering about your viewpoint on this one. And I think on the CBAS issue, someone was asking specifically about Alzheimer's Day programs for low-income elderly.
Say again? What was that?
I think someone is asking specifically about what happens with Alzheimer's Day programs for low-income elderly.
So, I guess it depends on. I'm not exactly sure of the funding source for that.
Right.
If it's not a Medi-Cal covered benefit or a Medicare covered benefit, then it's entirely outside of the CCI and will remain that way. If it's actually being covered by one of those two programs, then it would have. If it's CBAS, the health plans have to contract with all the CBAS centers. So I'm not sure if this is an adult day health care center that's focusing on Alzheimer's and therefore is then just a CBAS center. If so, then the health plans have to contract with them. That's a requirement. If it's outside of that, it would be, but it's still covered by either Medicare or Medi-Cal in some way, most likely Medicare. It kind of reminds me of maybe a home health agency. So they would have to be a contracted provider in order. If let's say the member is enrolled in Cal MediConnect and they're going to this Alzheimer's Day Center and Medicare has been paying for it, if they're now enrolled in the plan, that center would have to be a contracted provider with the plan in order to continue that relationship. Or they could disenroll from the plan and to continue that relationship. Or you could reach out to the plan and say, this should be one of your contracted providers. So there are a lot of different options, and that was not the best answer. So if you want to email me for a more coherent answer, definitely do that.
Right. The answer that I typed in the chat box pretty well assumed that the Alzheimer's elderly program you were talking about was a Medi-Cal funded program. So if that isn't the case, then yes, the lid sort of comes off on what happens. Okay, we're on to our last couple of slides. So let's just finish up here. There are some other consumer protections that can be very important to different beneficiaries depending on their needs. One is the right to receive materials and services in their own language. And this includes alternative formats such as Braille or large print or electronic disc. That communications, the CCI communications are supposed to be accessible and available in all the threshold languages. As well, there are some key accessibility rights. There was recognition by plans in the department that this is a new population going into Medi-Cal and going into managed care Medicare, and that it's a population that many had complex conditions and various disabilities. So those individuals, as individuals with disabilities, have a right to reasonable modifications to gain full and equal access to healthcare services and to LTSS services. So there's a requirement that there needs to be physical accessibility. Private, even completely aside from the fact that there is public funding going to healthcare clinics and providers' offices, those providers' offices have an obligation to provide physical accessibility to a threshold of being readily achievable. With the fact of federal funds and state funds being involved with Medicaid and Medicare dollars, there's even higher obligation I would argue to be physically accessible, and that includes looking at height adjustable exam tables and other diagnostic and medical equipment needed by people with mobility and other disabilities. The plans have also been required to receive training and give employees training on disability discrimination and cultural competency. I've actually been involved in some of that in the past, so I know it's going on. And here's our final slide that is just indicating how local advocates can help. The HICAP is an invaluable source of information with especially expertise around Medicare. The CCI Ombudsman is located. There are ombudsmen in all the 7 counties. They are legal services organizations, and they can provide information and advocacy and assistance on many levels. And if you're facing a grievance or a complaint or an issue that's arising for you, they are a great resource for that, as well as just getting information. I think with that, we are basically done with our presentation. If there are any more questions, you can type them in, and we have I guess our emails aren't on here. Are they?
The next slide.
Oh, I forgot there was another one. My apologies. Mm-hmm. There are, additional resources, of course. Justice and Aging has been a fantastic resource on all aspects of the CCI. As Amber mentioned, the Advocates Guide is available on the website. On their website, there are fact sheets, and you can sign up for alerts. Amber's email is there, and her colleague Denny is also there. We also have some resources. The Advocates Guide as well is on our website, and my email is up there as well. And then the Cal Dual site is an excellent source of information about the CCI in general. The slideshow will be available on your site, Amber, and the transcript as well?
We do it. I think you guys put it on your site as well.
Oh, right, because because it has the caption, the transcript.
Right.
So it will be available. Probably don't look today, but look in the next 2 days, and it should be up.
Yeah.
Thank you, everyone, for your attention.
Yeah, thank you, everyone, and do not hesitate to contact us with questions if you have them. Thanks, Silvia.
Thank you, Amber. Bye.
Bye-bye.